Today I'm speaking with Dr. Jayson Brower. Dr. Brower is a board-certified, fellowship-trained interventional radiologist practicing in Spokane, Washington. Dr. Brower went to college at UC San Diego and completed his medical school at St. Louis University in St. Louis, Missouri. He then went on to complete an internship at UCSF in San Francisco, California, and his residency training at UC Davis. Dr. Brower completed his training in vascular and interventional radiology with a fellowship at Brigham and Women's Hospital in Boston, Massachusetts. Dr. Brower, thanks so much for spending some time with me this morning.
My pleasure. Thanks, Mike, for the invitation.
Yeah, absolutely. So let's jump right into it. So take me back to the beginning. Where did you grow up? How'd you initially get interested in medicine and then eventually interventional radiology?
It's an interesting story. So I grew up in Southern California, born and raised. My whole family was in the Los Angeles area. We actually did not have anybody in the family in medicine, and kind of in the culture and the community that I grew up, quote unquote, good kids went into one of three different things. You were either a doctor, a lawyer, or a stockbroker. And I never really had any desire to go down the legal side of things. And I probably was too young to understand that if I was a stockbroker or an investment banker, I could probably do a lot better financially. But be it as it may, I was always interested on the science side of things. So, kind of developed an interest and a love for science. And that's what led me down to UC San Diego. I think it still is now, but certainly back in the day when I was there, pretty well known for its science training. They had a pretty good track record of getting their undergraduates into medical school. And so I thought that might be a great place to try to launch my career, and not a bad place to go to school on the beach there for 4 years.
Yeah, absolutely. That's a beautiful campus. So if you didn't end up becoming a physician or interventional radiologist, what do you think you would have pursued? What career?
It's interesting. People ask me that occasionally. When I was really young, I remember it was one of those elementary school projects, and people said, "Oh, what do you want to do when you grow up?" And I was naive enough to think that I wanted to be president of the United States. So for years, I was going to be president. I wanted to go into politics, and then sort of reality sets in, and the life that a professional politician leads was just not something that I ever had a desire to pursue. I don't know. I really didn't have a fallback. And it's interesting because at the time I was a non-traditional medical student, whereas now it's much more common to take a little bit of a circuitous path before you get into medical school. So I can make up any excuses that I wanted to. It's not that I partied in undergrad. I had a job, I worked, I took a full course load. But the bottom line is I just didn't study as much as I needed to. So my first 2 years, I didn't do as well as I should have. My last 2 years, I did great, but then I was in a bit of a hole. So I didn't apply to medical school right out of the gate. I came back to LA and went to graduate school. I was studying molecular biology. I never wanted to be a hardcore research scientist, but for me, it was a means to an end. Mm-hmm. Advance my degree, better my GPA, studied for the MCAT. And, I worked hard. It still took me 2 years to get into medical school. And after the first year, I was waitlisted. I think I was waitlisted at about 7 medical schools my first year. I was everybody's favorite second choice, but nobody's first choice. And I doubled down, reapplied the second year, kept working. And at that time, I figured I was going to broaden my horizon, actually applied to medical schools outside of the United States. And it came down to the wire. I was actually accepted at the medical school in Grenada down in the Caribbean. Mm-hmm. And so it's a long-winded way of saying I was ready to go because there was nothing else in life that I wanted to do other than become a physician.
Yeah.
I sent in my deposit, and literally 2 days after I sent in my non-refundable deposit, I was accepted off the wait list in St. Louis. And, I was funding all of this out of my own pocket back then. And so it was $1,000 non-refundable deposit. And I figured, well, I'm going to call them up and ask them what the worst they could do is say no. So I talked to a great gal in the registrar's office there, and she was so excited for me that I was able to get into a U.S. medical school. She said, "No worries, I'll rip up your check when it arrives. Good luck." And I kind of launched my medical career.
That's a great story. That's awesome. Persistence, And so that kind of leads into my next question. What advice do you have for, younger students, medical students, maybe applying for, medical school residency, matching, all of that?
Yeah. Never give up. I think persistence, your one word answer there really says it all. I say tongue in cheek. Where I work right now, we have a residency program. And so we see a lot of young folks come through. There are a couple of medical schools, and we're pretty actively involved in medical education. And I work a lot with the local high schools and the undergraduate students because I think I reflect oftentimes on those days and what a tumultuous time it is for all of us just to try to figure out how to get through undergrad, and then you're stretching and reaching for this other thing. And so I oftentimes say, listen, if I could get in, anybody can get in. So don't doubt yourself. If it's what you want to do, it may take a little bit longer, but there are great options and opportunities out there. I think the other thing we have going for us these days, and I find myself saying back when I was, or in my day, and I realize it starts to date me a little bit. I don't feel that old, but unless you were going into a traditional MD program back then, I think anything outside of that was rather fringe. Mm-hmm. Whereas now, I think the osteopathic program is so well proven that it's so integrated into the quote unquote conventional Western medicine. And in fact, we have a tremendous number of osteopathic docs in our group. I think the training is on par. It's a great option. And so it really expands the possibilities. And so that's the other piece of advice I would offer is don't forget about DO programs. Mm-hmm. I think it's a wonderful way and a great entryway into Western medicine.
Yeah, that's a great point. I think, DOs get a little bit of a bad rap, but like you mentioned, it's a great route, and there's plenty of excellent DOs out there in every specialty. So I think that's something I never thought of, but that's, I think, tremendous advice.
Yeah.
So you said, you don't want to date yourself, but I think you've been in practice for 20 years, somewhere around there.
Yeah.
Which is crazy to me. I didn't realize that. So, you obviously have a long history in interventional radiology. How has your specific practice changed and evolved from when you first started up until now?
So much of what I do now, I never had formal training for. And really what it comes down to, it's all variations on a theme. Your formal training gives you the building blocks to figure out how to do things safely. Particularly for interventional radiology, it's a lot of hand-eye coordination, dexterity, learning to use the imaging equipment. But at the end of the day, and I had one of my mentors when I was in training said, whatever you're doing now, it's going to evolve in some fashion. You're going to have to learn how to adapt or die. And I think that's really sound advice. And the tools that I think that allowed me to succeed, really being able to evaluate the clinical literature effectively and critically. I think training now is much more in tune with taking care of not only your patients, but yourself as a physician and individual. That was frankly severely undervalued when I was going through my training time. And it seems obvious. If you're not happy and healthy, there's no way you can be an effective member of a medical team. And that team concept, I think, is the other really important part. Again, I had some really good mentors along the way where, contrary to the traditional medical training back in the day, where the doctor was the tip of the spear or the top of the pyramid, however you want to look at it, mm-hmm. Now we're considered to be part of a team, and a physician is no more important than anybody else that's in the care continuum. And I think that's important for anybody entering into medicine to understand now. If you're going into it because you think you're going to be the boss, then pick another career. That's not the way to practice effective medicine.
Mm-hmm. Yeah, no.
So,
go ahead.
Go ahead.
No, I was going to say that's so true. It just makes me think, for me, I always was in love with baseball, wanted to be a baseball player. And I think of a baseball team, almost like the physician is the pitcher, maybe has a high role in the game, a very important role that sees a lot of action, but can't play left field, can't play shortstop, can't catch your own ball. So I think that's so true. Just integrated care, comprehensive with other specialties. So I think you make a great point.
No, thanks. No, I think the other important things, I look at my practice now, there's certainly things that I was trained to do that I still continue to do. And there's so much, even within the subspecialty of interventional radiology, and you can be good at a little bit or a lot of it. It's hard to be great in everything. Mm-hmm. And the natural instinct is you want to be great in everything and try to capture as much as you can. I think I've come to realize over time that that's probably an unrealistic expectation. You have to be able to do the basic duties of the job, but it's okay to say, hey, my partner so-and-so is much better at this than I am. Mm-hmm. If it was me or my family member, this is the person you want to see for fill in the blank. And you also have to be equally comfortable saying, yeah, I am the right person for fill in the blank. Mm-hmm. And so I think there are some things that I've gravitated to more over time in my practice that I spend more time doing. And there are clearly some things that I lean on my other partners more for their expertise.
Mm-hmm. So, looking at interventional radiology, can you explain exactly what interventional radiology is? I'm sure there's tons of patients out there that aren't familiar with that specialty, and there's even physicians that aren't familiar with that specialty. I've been in spine surgery, neurosurgery for 15 years, and I'll talk to a spine surgeon friend of mine and kind of talk about the things that we're doing in interventional radiology, and it's a lot of times just kind of a blank stare. So I guess, can you just explain simply what interventional radiology is, what you guys do?
Right. So I best describe it, and it depends on the population that I'm talking to. So within the medical field or people that understand imaging, I tell folks that I'm an image-guided, minimally invasive surgeon. And then I'll sometimes expand on that and ask people if they understand what a CAT scan is or an ultrasound. And then I'll explain, well, I use those imaging devices to do procedures that might have otherwise necessitated a big open surgical procedure. Now I could do it through just a little poke hole in the skin. And oftentimes they'll say, well, that sounds kind of interesting, to give me a couple of examples. Mm-hmm. And so in my practice, I specialize primarily on the interventional oncology side of things. And so I'll talk a little bit about the tumor treatments that we do. And then for others, I'll basically explain it if they have really no medical training or insight at all. My general statement for what I do is basically I'm a plumber for the human body. I fix things that are broken. If it's leaking and it shouldn't be, I plug it up. And if it's plugged up and it shouldn't be, then I open it up for them. Mm-hmm. So at a real high level, that's what it comes down to.
Yeah, no, that's I love that explanation. It's so true. So with that, again, maybe talking to patients that aren't familiar, what sort of treatments, procedures, and therapies do you offer patients as an interventional radiologist?
Most of the time when the patients come to see me, they're being referred in from one of their other doctors, and it could be a primary care specialist, an oncologist, for instance. So I'll really direct the conversation to whatever they come in for their referral. And we'll take oncology, for instance. They may understand that they have cancer somewhere in the body, and we'll pick on colon cancer because it's fairly prevalent in our society. Colon cancer, if it spreads, it oftentimes spreads to the liver. And so that's what they're getting referred to me for. So when we sit down, the first step is always understanding or helping them understand and set the basic level. Sorry, someone's knocking at the door. Come on in. We can circle back on that.
No problem, yeah.
Thanks, all. You want me to rewind to the beginning for your editing, or
No, you're
just
good.
Keep going?
Yep.
Okay. So, if they're coming to me and they know that they have cancer, I oftentimes I made the mistake early on in just assuming that people know that when they come to see me that we're here to talk about their liver cancer. So I just engage in conversation to make sure that they understand, yes, they do have colon cancer. We'll use that as our example. And yes, they understand that they have it in their liver. Mm-hmm. And then from there, we'll say, okay, so your doctor has sent you to talk to me about potentially treating the cancer at the liver. And then we'll go through a description of whatever the procedure is that I think is most relevant for them. And that could be anything from an ablation type procedure where you take a a probe device and you use imaging guidance, whether it's CT or ultrasound, place the probe into the tumor and you kill it with some sort of thermal source, hot or cold. Or they're coming to me for a liver embolization procedure, where we take a particle that has either chemotherapy or radioactivity on it, and we put those particles directly in through the blood vessel into the tumors in the liver. So it really starts with making sure they understand why they're seeing me, and then talking specifically about the treatment that I think is reasonable, but then other treatments as well.
Mm-hmm. Yeah, and so, you're with Inland Imaging, which is a very successful and popular interventional radiology practice, and most interventional radiologists are within the hospital, right, contracting with the hospital. And so I guess what I'm trying to get at is most times patients will see an interventional radiologist in the hospital and really not have to prepare all that much for a visit like they would, maybe going to a different specialty. But I guess at your practice, how can patients, best prepare for a visit with you? Their specialist says, hey, you need to go see Dr. Brower at Inland Imaging. What can they do to best prepare for a visit with you?
So a couple different thoughts on that. One, the internet now and all the information you can find out there, both good and bad. But I think educating yourself as to whatever the disease process is always a great step up. I always caution patients, though, you have to be careful, because there's so many nuances to what we talk about, and there's a lot of focus and attention sometimes on the downside, and the upside at times can get lost in the shuffle. Mm-hmm. And it's all about putting the entirety of the patient experience into perspective. And, not all patients with cancer are the same, and not all colon cancers are the same. And so it's making sure that we talk through those pieces of it. For our practice in particular, and I would say this has been a great evolution in the specialty of interventional radiology. Way back when, I think you were absolutely right, it was all hospital-based. You didn't really see the patients until they showed up in your procedure room ready for the procedure. Mm-hmm. As a specialty, we've tremendously evolved in the area of patient care and clinical care. And so our practice, like a lot of practices out there, we actually run an office in a clinic setting. So much like any patient would go see their primary care doc or a surgeon, an orthopedic surgeon prior to having their spine surgery or their shoulder done, they come and they sit down with us in the office that is separate and distinct. That visit is completely isolated from whatever the procedural visit is. So we can talk through the procedure so they can understand what's involved. I think the other really important lesson that I've learned over time, when you first come out, you're excited. You see every patient as an opportunity to do a procedure. And I think as I've matured in my practice, one thing that I talk to all my patients about is sort of the quote unquote cost of having something done. And I mean that not just the financial aspect, because that is a real burden to bear, but the psychosocial and family impact of all of these treatments. And again, so much of what I do is treat cancer. And sometimes by the time patients come to see me, they've been through multiple cycles of chemotherapy and surgeries. And I oftentimes start out by telling my patients, it's okay to say no. I'm not here to sell you on a procedure. I'm here to provide you with information and opportunities. And so that clinical part of the visit, being separated from the procedure, I found is really important, so patients can go back and digest the information and realize that really they have the power, they have all of the authority. We're just here to help them through their journey.
Yeah, no, that I think that's tremendous. The way you mentioned you don't look at every patient as a procedure. I think that's key, because there's certainly physicians out there, and I don't know if you've seen that Dr. Death podcast or show that just came out recently. So I think there is a lot of scrutiny in what physicians do, and certainly I think your perspective there is spot on. So I know we have to kind of hustle through a little bit, but I wanted to ask you, you mentioned colon cancer as an example of something you treat. What are, I guess, some of the more common organs that you deal with You mentioned the liver. I know I originally met you when you were teaching a course on the management of compression fractures in the spine. Can you talk through kind of the common areas that you treat in the body?
Sure. Yeah. So we do a lot of spine work. I do a lot of spine work in our practice, whether it's a compression fracture that's just related to osteoporosis. And for the medical people that may see this, they'll know exactly what that is. But osteoporosis is basically weakening of the bones, and that's due to a lot of different factors. The spine can compress. It's just basically building blocks stacked one on top of another. And if they fracture like any bone in the body, it can create a lot of pain. And so there's a procedure, a technique to put some special bone cement in to stabilize that fracture. I describe it as an internal cast that fixes the bone in place and really helps alleviate the pain. So you can get fractures just from plain old weakening of the bone. You can get fractures from tumor in the bone, or what they call a pathologic fracture. And for those patients, in addition to just putting the cement in, we'll also do that ablation procedure I mentioned. You put a probe in and then you kill the tissue using heat in that case. And that helps really treat the tumor at its site, stabilize the bone, and then improve quality of life overall. In some cases, it's potentially a local cure. In a lot of cases, it's really part of the overall treatment algorithm. Patients are also getting chemotherapy or radiation, so it just helps in a broader treatment perspective. Mm-hmm. So that's bone, for instance. We do a lot of liver-directed therapy with embolization procedures, putting particles into the liver for tumors, also those ablation procedures. I would say areas that we have grown lately, men's health has been a tremendous focus, and enlargement of the prostate is a problem for men as we age, and it can result in what is called lower urinary tract symptoms, difficulty voiding, frequency voiding. And so we will do that same embolization type procedure where we put little particles into the blood vessels, but now specifically targeting the prostate to shrink the prostate and improve the symptoms. Previously, the only options for something like that were surgical interventions where they would do a TURP procedure or transurethral resection of the prostate or lasers. And so it's a minimally invasive way to achieve similar results, oftentimes with a lot less risk and side effects. So that's been an area we've grown. Mm-hmm. Our practice is still very active in peripheral vascular disease. That's more of an exception than the norm for interventional radiologists these days, but we spend a lot of focus on that. We do a lot of hospital-based work. We're one of the largest hospitals. In addition to working in a hospital, our group has an outpatient procedure lab as well, but mm-hmm. the hospital work focuses on things like trauma. We're the primary stroke center. So I also do acute stroke intervention. And I would say that's kind of the more glamorous types of procedures. There's a lot of bread and butter procedures we do as well. Venous access, maintenance of dialysis access, drainage of abscesses and infections. And we do a lot of biopsies for diagnoses in our practice as well.
Yeah, it's a lot. You mentioned
it's
earlier,
a fairly broad.
It's hard to be an expert at all that, but so kind of looking a little bit deeper at the spine work that you do. I know you've been involved in treating compression fractures for some time. You've been involved in writing some articles and research in and around that. And I've heard physicians say that treating a compression fracture is one of the best things that physicians can do in medicine. And can you just kind of talk through what your experience has been in seeing some of these patients get relief from an osteoporotic compression fracture or even a pathological compression fracture?
Absolutely. The pain related to fractures anywhere, but in the spine in particular, is so debilitating that it's hard to diagnose when you have a spinal fracture. Oftentimes patients just present with pain and no trauma associated with it. And by the time they're diagnosed, they're now months into this pain cycle. They're taking high dose narcotic therapy. They've become immobile. Their normal activities of daily living have been severely impacted. And so by the time we see them, they're grasping at straws for anything. The procedure itself, it's quick and easy. It's an outpatient procedure. If you have a single level fracture, I tell patients in our practice that's about a 15-minute procedure and about a 1-hour recovery time. And when you look at all the statistics that are out there, somewhere between 80 to 85% of patients have significant immediate or near immediate relief of their pain. And so to your point in the question, the gratifying part of it is when you see a patient pre-procedure and they can barely move, and then an hour later, they're up, they're sitting, they're walking around nearly pain-free. It's one of those few times in a medical career where you have that immediate feedback loop of they were broken and now they're fixed and now their life is going to be better. Mm-hmm. That part to me is tremendous. I think the other part, particularly in the spinal compression fracture, again, kind of going back to the beginning with it's so hard to diagnose. Again, there's lots of studies that show that once you've had your first osteoporotic fracture, you're at increased risk of developing subsequent fractures. And these patients have been put through the meat grinder to get their diagnosis. And now I'm able to say to them, listen, unfortunately, you're at higher risk, but here's my card and here's our office number. If you develop additional pain, you don't have to go through that again. Call us directly. We can expedite the whole process. And so that kind of closes the loop on the whole patient care portion of it. That also it's gratifying to be able to do that for patients. And unfortunately, we do see a fair number of these patients come back.
Yeah. And so, you're talking about, you do a lot of oncology work, and a lot of times patients get referred to you by another primary care or oncologist. How have you educated, oncology, for example, on the benefits of the ablation procedure that you do for spinal metastases?
It's a lot of one-on-one conversation, and this type of interaction we're having this morning and the ability to get something like this out is tremendous. So I really appreciate that. Mm-hmm. But it's discussions, it's tumor boards. In our practice in our hospital setting, we have tumor boards Monday through Friday at 7 a.m. So literally 5 days a week, and oftentimes 2 days in the afternoon. We've made it a point to have one of our interventional radiologists at every single one of these tumor boards, and we've made the distinction. They're not there to present the images. They're there as a clinician, as a treating colleague, so that we can talk about treatment algorithms. Now, the flip side of that is you have to know the data and you have to be able to speak intelligently and educatedly about the whole process. So there's a lot of work we have to do on our part, but it's education, education, education. We do lunch and learns. We meet folks for breakfast and have coffee. We try to close the loop when we've done a procedure to get back to the referring clinicians. They always get our post-procedure notes. They get our post-office clinic follow-up visit. And then we also try to connect with them and say, hey, Mr. Jones came in, as you recall, with this pathologic fracture at T7. We did an ablation augmentation. Here's where their pain was before. Here's where they are now. Here's our plan for what we're going to do to follow up. And that's the other key, is when we take some of that burden off of them for following up on something that they really don't have a lot of knowledge about. It's not their primary pathway. Mm-hmm. They're appreciative and they remember that, and then they call us back for the next case.
So, you talk about education. If you're at a tumor board or just one-on-one with, say, a medical oncologist, radiation oncologist, and talking about the, ablation procedure for spine mets, how are you educating them and kind of helping them feel more comfortable working alongside you as an interventional radiologist to treat these patients? Because in my experience, that conversation can be difficult with the oncology folks, and so I just wonder, how do you go about that?
It's a great question, and I think I approach all of these colleagues in the same mindset, but realizing you have to adapt the message depending on who you're talking to. I think the most important part of the whole discussion is reinforcing the notion that I'm here in a collaborative fashion. It's not a zero-sum game. My procedure is part of the overall treatment algorithm. It's not a substitute for whatever else this patient may need. And so particularly in the spine, we are, I was going to say rarely, probably never treating primary cancer of the spine. It's almost universally metastatic disease from somewhere else. By definition, in my mind, they need systemic treatment if they can have it or if they haven't already have it. So they're going to need chemotherapy. And so it's working hand in hand with the medical oncologist. By the same token, adding radiation therapy on top of ablation and augmentation has been shown to be a very effective combination of treatment modalities. And so if I'm speaking to a radiation oncologist, I may discuss things like, I know you're going to see this patient for, and it could be tumor control, it could be for pain control. Oftentimes it's both of those things. And what the physician sometimes doesn't appreciate, because they're in the back doing the radiation treatment planning, they don't put the patient on the table, they don't see the pain. And so I'll speak to the radiation oncologist about, let me help you and your practice by getting this patient out of pain immediately. We'll do some local ablation to help treat a volume of tumor. They're still going to need the more definitive external beam radiation, SBRT, whatever it is they're planning on. And so it's really a combined multimodality approach. And I think those oncologists, radiation medical oncologists, they're used to thinking about combined therapeutic approaches. Chemoradiation it's a buzzword because they do those things together. Mm-hmm. Now it's just adding one more tool to that overall combined approach. And I think once they realize that it's not an either or, that we're there to help them, and then they see the benefits of what we're able to do, I found that was a very effective way for us to build our practice. Mm-hmm. And kind of the last piece of that, we were fortunate enough to get involved early on in some clinical trials. And anytime you're able to present to your colleagues, this is what we're doing, here's how we're participating in medical research, I think that also ups the level of the validity of what you're trying to do. It's not selling a procedure. We think this is beneficial. We're gathering objective scientific data, and we want you to be part of the process as well.
Mm-hmm. Yeah, no, I think, looking at that, you're on the spine metastasis side of it. You're there to treat their pain and get them as reduce their pain as much as possible, so they can have those other systemic therapies. And I think everything you just pointed out is great. So looking at kind of the tools you use in your procedures for compression fractures and treating, using ablative therapies for treating spine mets, we originally met at a course where you were teaching. It was actually on Define's technologies, and Define's been acquired by Merit Medical. For maybe those physicians out there that aren't familiar with the Merit Medical technologies, what would you say to them about what Merit offers instrumentation-wise?
And take my opinions with a grain of salt,
Sure.
Because I think you pointed out I've done work with them before. I haven't in quite a few years now, but it's still the only product that we use for our spine work. And I think it offers some significant advantages. Number one, it's an all-in-one system. So from beginning to end, it's a kit. You don't have to worry about, if I use brand A and brand B, will it work together? So I know the system works. There are other systems out there that also come as a kit. So, that's a universally accepted approach now. When we started doing this way back when, it was always cobbling something together. What I like about Merit primarily, the instruments are articulating within the spine, so I control when and where and how much I want the instruments to move. The ablation probes in particular likewise are articulating, so once I've created a channel within the bone, I could pass that probe through that same channel. I can move it to a different channel, so I have very precise control over that. It's, the quote often was, the tool was purpose built for ablation in the spine. And it's just from the bevel at the tip to the articulation to the visibility. It has built-in thermocouples at the tip of the ablation probe. So you're actually measuring the temperature. And when you do an ablation, it's the heat or the increased temperature that kills the tumor. It could also kill normal cells. And so you want to be very careful when you're working around the spinal cord and the nerve roots that you're not causing damage to those structures. So the built-in thermocouples let you measure the temperature at the ablation zone. It gives you direct, immediate feedback, both visual and auditory, that you're achieving the ablation that you want. So, bar none, in my opinion, it's the best tool out there still to this day to do ablations in the spine. Mm-hmm. And then the cement that you use to stabilize afterwards, I feel it's a superior cement. Just the the viscosity or thickness of the cement is better. The visibility is better. It's easy to use. There's lots of built-in safeguards that I like about it.
Yeah. No, thanks for sharing that. And, it's fun when I'm finally able to, do a procedure with a physician for the first time and they use that steerable technology and they're like, oh, wow, this is great. They really like it. It saves time. It's targeted, like you said. And so I think once a physician tries it, I think they'll see the benefits. Taking a step back, because my brother-in-law is a urologist, and so kind of that same conversation, looking at men's health, what kind of conversation are you having with your urology colleagues about what you can offer, men in treating, prostate and BPH and all that sort of stuff?
Yeah, it's a little more challenging discussion now. It's getting easier, but we took that same approach, that collaborative approach, the educational approach. We were, again, fortunate enough to be part of a clinical trial early on. And I realize our practice is unique in that regard. But there's two ways in my mind you can go about building a practice. You can be a little bit bullish about it and just say we're going to do it, or you can try to be collaborative. And that's the approach that we've always tried to take. And so we started small. We started with the occasional case here and there. And I thinking back, I think the very first case I did was self-referred by the gentleman to our practice. I'm a firm believer that we need to have a urologist on board. So I worked with the urologist that I felt was going to be most receptive to the concept. And together we sort of went down a path of trying to put together an algorithm of what patients we thought might make sense to have a prostate artery embolization versus traditional surgery. I think over time, as they've had new partners join their group, they've also been receptive, and we've grown that part of our business quite a bit. There's a lot of discussion amongst my partners now. Do we market directly to the public? How do we get the message out? Because it's still, I think, an underrepresented treatment in the overall paradigm, and so we're struggling right now with how we can get the message out effectively without alienating our urologists. And fortunately, social media is the great equalizer. We've been lucky enough to have patients that have done well that are posting on social media. I think men that are looking for alternate treatment options and their surgeon might not recommend this procedure, they're finding it all online as well. And so the online presence has been, again, a easy way for us to get the message out without necessarily the self-promotion. We still come back to the underlying tenet, though, that if someone comes to us self-referred without a urologist on board, we still get our urology colleagues involved because it's important to have that collaboration.
Yeah, and so, speaking to a urologist, you mentioned it a little bit, defining what patients are maybe a good candidate for prostatic artery embolization versus, what a urologist will do, a TURP or some sort of procedure. What would you say that algorithm is? If you're speaking to a urology colleague, what, in your opinion, what patient fits for a PAE?
So there's the really kind of easy, obvious ones, very large prostates. And I think that's a bit of a moving target for the definition, but 150 grams plus starts to get into that. It makes surgical options a little more challenging. Patients that are on anticoagulation or blood thinners, a lot of those patients, they don't want to stop that if it's for cardiac reasons or stroke reasons. Those are difficult patients for the urologist to treat surgically because they have to then stop their anticoagulation. For us, we don't stop any anticoagulation when we do our treatment. So those two are kind of no-brainers. Patients that have a lot of comorbidities that may not be a great candidate for general anesthesia, our procedures are done with conscious sedation. So another great kind of no-brainer category. On the other end of the spectrum, you get patients that have very small volume prostates, and there's other tests, urodynamic tests, for instance, that need to be done, and they may not have the classic symptoms that then fit with the benefits of this treatment process. And so those get segregated into not great candidates for us. And then there's a whole swath of patients in the middle And I feel that, it's about offering choices and letting patients make an educated decision.
Mm-hmm.
I'm always upfront with my patients when they ask me about the outcomes and say, in the big scheme of medical treatments, this is a relatively new procedure. We're coming up on 10-year data now. It looks promising, but the surgeons have decades and decades of data on their time-proven surgical outcomes. I think we're going to be in that same ballpark, but I can't lie and say, oh, we're as good and we'll always be as good. Right now, we think we're as good, and right now we know that our side effects and complications taken as a whole are lower than what they are for a traditional surgical approach.
Mm-hmm.
But, not every disease or patient is a hammer and a nail. You have to really tailor your approach to the right patient.
Mm-hmm. No, I think that's important, and that's great to hear that the side effects and complications are at this stage of the game lower in some of these scenarios. So I know you were on call and you got to go here pretty soon, and so I have hopefully 5 more minutes if we can knock this out. I'd like to just talk a little bit about medical device reps, your experience with medical device reps. So I guess in your experience, what would you say separates the excellent medical device reps from maybe the average or below average?
Probably in a word, sincerity. I've got 2 of my best friends are device reps that I met through work when I moved to town here. And, from the outset, I never felt like I was just an account or just a person to sell something to. And so for me, and it probably carries through in everything that I do, that personal connection has been extremely important. I realize the value that my reps bring to the table, because while I may see, and we'll come back to the spine, in the course of a year, I'll make up a number. Maybe I do 100 spine cases. I know that my rep is in all of my cases plus 50 other docs' cases. And they have so much knowledge. I really value what they bring to the table, as long as I feel like it's kind of that bi-directional partnership. So sincerity, I think you need to be educated about what you have to offer and what your competition is. And sometimes, well, not sometimes, it's okay to acknowledge that your competition is okay or that they're good. But you have to be able to say, mine is as good, mine is better. And when I look at the products that I use or think about changing products, it comes down to, is there a clinical advantage? Is it safer? Is it more cost effective? If you hit on any one of those 3 things, I'm interested. If the answer is all those 3 things are the same, then it comes down to who is the person that I'm working with, mm-hmm. and do I want to see this person, and do I trust them, and do I feel like they're looking out for me, my practice, and my patients?
Yeah. No, that you touched on a lot of good points there, and one that I just want to kind of hit on is you mentioned your reps in all your cases plus cases outside the community or other physicians in the community, and I think that's a key point. I think as medical device reps we have a sort of a unique perspective because we get to see a lot of different physicians and a lot of different teams, and we pick up different things along the way, and so I think that is a key value that medical device reps bring, at least the good ones. Yeah. And then I guess kind of looking forward, there's a lot of change in healthcare and everything in general. How do you see the role of the medical device rep evolving in the next 5-10 years?
I think we're all going to have to be more comfortable with this type of venue like we're on this morning, the whole video interaction. You've referenced some of these training courses I've done in the past, and they were always in-person training courses. Now I'm working with a couple of vendors where we're bringing in video systems to watch live cases. And in some respects, I think it's much more educational, because you can always, when you come to these conferences, you could always make things look pretty, and you could minimize the headache and hassle factor. When you're in a live case, everybody sees exactly what's going on. There's no way to hide your dirty laundry. Mm-hmm. So I think that's an advantage. But for the sales rep interaction in particular, I would imagine it's going to be more challenging. If you can't develop that initial personal relationship, how are you going to convince a busy physician, administrator, lab lead that, hey, I need 15 minutes of your time on video. And it's really easy, as you've seen this morning, people come and go through the door. It's really easy to get distracted. And so you're going to have to think creatively. Mm-hmm. I think you're going to have to be willing to put yourself out there maybe a little more than you would have otherwise. So I would say that's probably the single biggest change that I see coming. I think the other part of it is the regulations that get involved with anything related to hospitals. It's a pain and it's frustrating. And again, I hear my friends that are in device complain about it, and I appreciate that, but that's the cost of doing business. So realize going into it now, it's only going to get more regulated. It's going to become harder, not easier, and you have to be willing to jump through the hoops.
Yeah. So is that the video system that you're referencing? Is that Avail by any chance? Is that the one that you?
That's not the one, and I can't recall the name. There's two different ones that we're in the process of bringing into trial, but they all basically do the same thing.
Yeah, it looks pretty cool to me.
Yeah. There's one that has, I think, 3 or 4 different cameras in the room. One pointed on me. It's sort of like a GoPro pointed at my face or my hands. There's one that looks at the monitor and one that looks at the patient. And yeah, they're interesting systems.
Yeah, I think that's very neat. So kind of looking at that, on the flip side or for your specialty, what opportunities or technology, I think you just hit on it with this video, but what are you most excited about sort of in the next 5-10 years for interventional radiology?
So I think the adaptation of practices that we have now for new disease processes, we'll pick on men's health again, for instance. I wrote up a research protocol to adapt the yttrium-90 is the radioactive bead we use for liver cancer for men with prostate cancer. I'm working with a urologist on the other side of the state who is kind of involved he's at one of the large universities. And so I'm hopeful that our protocol will be well received. We're kind of working through some of those channels, but I think men's health, there's a huge leap forward. I think we're going to continue to see new treatment opportunities in the world of oncology all around the board. Immunotherapy, for instance, being applied in unique fashion. Those are probably the 2 areas that I'm most excited about. Again, in some of the other areas that we continue to do treatment in, I think just refining the tools that we use now, make them smaller, more durable, better performance.
Mm-hmm. You mentioned, we talked a little bit about discussions with your oncology and urology colleagues. And I've heard a lot of docs tell stories about, I think it was in the 90s where interventional cardiology began to become more popular as a specialty. And there's some turf war between the cardiology and the interventional cardiologists. And I feel like I'm seeing that now with spine surgery and what interventional pain management are doing and interventional radiologists are doing with some of those advanced spine procedures. Where, in your mind, I don't know if you're doing any of those procedures outside of treating compression fractures, but where do you think that line in the sand is between, what some of the traditional spine surgery procedures are and interventional pain, interventional radiology, stepping into that space?
I think data needs to rule the day. And kind of as we were talking about with the prostate, there are these other procedures that we think are going to work well, but we need to have the data to back that up. And then I think the next part of that is whoever does the procedure the best and has the best outcomes should be doing the procedure. And just because I have traditionally done something as an interventional radiologist doesn't mean it's my turf forever. And it's more, as we started this discussion, it's more than just doing the procedure, it's taking care of the patient. Anybody can do a procedure and then forget the patient, but oftentimes one procedure doesn't solve the problem. And sometimes you need to add a nerve do that or are unwilling to see the patient to understand do they need to have that done, then your patient deserves to go somewhere else.
Mm-hmm. No, I think that's, that that can be challenging for some physicians to say. So I really appreciate your comment on that. So that's kind of all the questions I wanted to get into, and I appreciate your time. But I have one more thing. So I was thinking of something that we might be able to do. Yeah, it should only take a couple minutes. You've seen that movie Slumdog Millionaire? Have you seen that?
Oh yeah. Uh-huh.
So I was trying to think of kind of a fun game to do, and so I thought of it's something. I call it Slum Doc Millionaire. So
I love it. Okay.
So I have 10 questions for you based on what I think your life experience is, and I just want to see how well you can go through these. So
perfect.
Couple minutes on this. So what is St. Louis University's mascot?
That's the Billiken.
That's right. What is
Couldn't tell you what it is.
Yeah, what is a Billiken?
I have no idea, but that's him right there.
Yeah. All right. Next question. Can you explain how to calculate the French size of a catheter?
Yeah, it's some complex. It's not. It's a mathematical calculation. It's like 2.2 millimeters per French or something along those lines.
Yeah, I don't know. And sorry, I don't have a phone a friend or anything set up yet. When I Googled it, it said the French size of a catheter is determined by multiplication of 3. So the diameter is in millimeters multiplied by 3. So
I see. I was partially correct.
Yeah, we'll give it to you. All right, so you were at, you lived in the Bay Area, UC Davis, UCSF. What is the largest river in California that empties into the San Francisco Bay?
Ooh. The Russian River.
I don't have the text here, but it's the Sacramento River is the largest river in California.
Okay, I missed that one.
I grew up Reno, Tahoe area, and I didn't realize that. So, all right, so you've also spent some time in Southern California. Have you ever been to Tijuana?
Yes, I have multiple times. There are probably some pictures floating out there from those trips.
That's true. There's a picture of you right there. Yep.
Yeah, that's about right.
Yep, coming back, it looks like. All right, where does the name Spokane, you live in Spokane, where does the name Spokane originate from?
The local Indian tribe.
Yep. Looks like it means children of the sun, Spokane.
I did not know that.
Yeah. All right. Oh, you kind of see the picture there. Who is considered the father of interventional radiology?
Charles Daughter.
Yep, there he is, Charles Daughter. So what's it looks like? 1964 described angioplasty.
Yep.
Crazy.
And he was experimenting on himself with Coumadin. That's how he ultimately passed away.
That's right. I forgot about that. Crazy. All right, a couple more. So number 7, can you spell polymethyl methacrylate?
Oh my gosh. POLYMETHYLMETHACRYLATE. How'd I do?
It's a long one. I don't know. We'll have to go back to the tape on that one. I think that's the first time I've ever been able to pronounce it correctly. So
you did a good job with it.
All right, a couple more. Who invented radiofrequency ablation?
So I don't know the specific answer, but I'm going to give credit to my mentor from my residency, Dr. John McGann. Whether or not he invented it, he was one of the early pioneers, just an all-around great guy. So if McGann, if you see this, miss you, love you, buddy.
So according to Google, Norm Shealy.
Okay.
He's credited with the invention of transcutaneous electrical nerve stimulation, spinal cord stimulation, radiofrequency ablation for back pain. So I don't know. I saw a couple other names on there. So
that's probably right.
I don't know.
I'll just give McGann the credit anyways.
Yeah. Well, you're right, McGann. All right. So you spent some time in Boston. How tall is the Green Monster?
85 feet.
According to this, it's 37 feet tall. And it was originally built to keep out spectators from watching the game from the street, which is pretty interesting. All right, final question. I don't even know if this is a real question, but what is the inner diameter of the base of vertebral artery? Is there a basal vertebral artery? That's what I'm trying to figure out.
Yeah, 1.2 millimeters.
Yeah, I have no idea. I was looking it up, and this is the only picture I could find. And is there a basal vertebral artery? Because it points and says nutrient A right where I think it would be.
Yeah, it's sort of a complex, but yes.
Yeah. Is there ever a world where you navigate into that and do spine therapies through, catheterizing it?
Um, to this point, no. I'd have to phone a friend on that one. I've got a neurointerventional partner who may know the answer to that one. But I think the important thing for us, though, is when you're doing ablation in the spine, that vascular complex potentially acts as a heat sink to sump away the heat you're trying to deposit. So it's important to be able to measure the temperatures at your ablation zone, and that's one of the reasons why.
Gotcha. Well, Dr. Brower, I certainly appreciate your time. I know you were up early on call and spent, a good hour with me this morning. I have some ideas on where we can take this conversation maybe next time if we have a chance to speak in the future. But really appreciate your time and enjoyed the conversation and looking forward to catching up with you again sometime.
I appreciate it. Thanks so much.
Yeah,
Good seeing you, Mike. Take care.
You got it. You too.